Welcome to This Week in Physical Medicine and Rehabilitation. This week we're covering 9 notable papers spanning health systems and post-acute care, advanced neuromodulation technologies, and the future role of our specialty. Let's dive in. Our first theme this week centers on optimizing post-acute care pathways and systems. How we define, measure, and structure care after an acute event has profound implications for patient outcomes. A special communication in the archives of physical medicine and rehabilitation provides a foundational vocabulary for these discussions. The authors define key terms used in quality programs by the United States Centers for Medicare and Medicaid Services, such as quality measure, outcome measure, and risk adjustment. They review established frameworks, including Donabedian's model and the Institute of Medicine's aims for healthcare. This paper serves as a vital primer for clinicians and researchers engaging in quality improvement, ensuring everyone is speaking the same language when we talk about value and outcomes. With that framework in mind, a systematic review and meta-analysis, also in the archives of physical medicine and rehabilitation, evaluates a real-world example of a large-scale system, Taiwan's nationwide post-acute care program for stroke patients. The study. Researchers synthesized data from 33 studies involving over 10,000 stroke survivors to assess the program's impact on function, healthcare use, and cost-effectiveness compared to traditional care. Results. The results were impressive. On average, patients in the post-acute care program saw substantial functional gains, with a pooled improvement of over 25 points on the Barthel Index and 16 points on the Berg Balance Scale. Compared to traditional care, the program delivered superior recovery, significantly lower 30-day readmission rates, and nearly a 50% reduction in acute care costs. However, the authors noted that gains were smaller for older patients and those with more severe strokes, suggesting a need for more personalized strategies for these subgroups. Conclusions. This meta-analysis provides strong evidence that a structured, nationwide, post-acute care program can be both clinically effective and cost-effective, offering a scalable model for other healthcare systems grappling with aging populations. In contrast to the structured success in stroke care, a second study from Taiwan reveals a critical gap in care for another vulnerable population, older adults with hip fracture. The study. This nationwide retrospective cohort study analyzed data from over 10,000 older adults after surgical repair for a fragility hip fracture. The goal was to understand the association between different rehabilitation pathways and dosages and 3-year mortality, particularly in a system with very short hospital stays. Results. The most striking finding was a massive care gap. More than half of the patients, 55.8%, received no post-operative rehabilitation at all. This absence of care was associated with a 17% higher risk of all-cause mortality at 3 years. For those who did receive therapy, an integrated inpatient to outpatient pathway was linked to the best outcomes, reducing mortality risk by about 1/3 compared to no rehab. Furthermore, a clear dose-response relationship was observed. Receiving 4 or more rehabilitation sessions was associated with a significantly lower mortality risk. Conclusions. The clinical message is urgent. In systems emphasizing early discharge, failing to provide structured, integrated, and sufficiently dosed rehabilitation for post-hip fracture patients is common and associated with increased mortality. This highlights a major target for quality improvement. Effective system design requires not only robust pathways, but also the ability to stratify patients early. A study in the Journal of Rehabilitation Medicine used a decision tree analysis to identify patient profiles during an ICU stay that predict discharge destination. Analyzing 300 critically ill patients, the model identified combinations of factors including illness severity scores, ICU length of stay, functional status, and age. For instance, a profile of lower initial severity but a prolonged ICU stay was associated with a non-home discharge. Conversely, patients with higher initial severity who preserved functional mobility and were under 80 years old were more likely to discharge home. Such models could help rehabilitation teams identify high-risk patients earlier and allocate resources more effectively. Finally, rounding out our theme on care systems, a qualitative study in disability and rehabilitation reminds us about the crucial, often overlooked role of caregivers. Through interviews with 14 people with limb absence and 15 of their caregivers, researchers explored the hospital-to-home transition. The study revealed that caregivers often felt marginalized during the inpatient rehabilitation process, leading to a disconnect between their expectations and the patient's actual functional abilities at home. This placed a significant physical and mental burden on the caregivers themselves. Participants identified gaps in information, care continuity, and social support. The findings underscore the need to centralize caregivers' perspectives and integrate them into the rehabilitation plan from the beginning to create a truly supportive transition. Our second theme examines the intersection of hype versus reality in neurorehabilitation technology, featuring a mix of promising, nuanced, and negative findings. First, from the Journal of Neuroengineering and Rehabilitation, a retrospective analysis looked at robot-assisted gait training, or RAGT, for stroke patients. The study, researchers analyzed real-world data from nearly 3,000 inpatients at a single rehabilitation center to compare the effectiveness of RAGT against conventional treatment. They also looked at differences between 5 different robotic devices. Results. Overall, the study found that RAGT was not superior to conventional treatment for improving functional ambulation. However, the story changed when looking at specific devices. 2 devices, the morning walk and the ExoWalk, were associated with significantly higher odds of functional improvement compared to conventional therapy. In contrast, another device, the Ergo, was associated with lower odds of improvement. The analysis also identified patient characteristics, like balance and cognitive scores, that predicted who would benefit, suggesting that specific devices are better suited for specific patient profiles. Conclusions. This study moves the conversation beyond whether RAGT works to which RAGT works for which patient. It's a call for tailored interventions rather than a one-size-fits-all application of robotic technology. Also in the Journal of Neuroengineering and Rehabilitation, another study explored an emerging technology for a different population, transcutaneous spinal cord stimulation, or TSCS, for motor complete spinal cord injury. The study. 10 individuals with chronic, motor complete cervical or upper thoracic SCI received lumbosacral TSCS for at least 6 weeks. The primary goal was to see if stimulation could enable voluntary leg movement and to identify markers that distinguish responders from non-responders. Results. The results were a source of cautious optimism. 5 of the 10 participants, exactly half, regained the ability to produce voluntary, anti-gravity knee extension and ankle dorsiflexion, but only while the stimulation was active. The other half did not respond. The investigators then tried to figure out why, using a battery of neurophysiological tests. Unfortunately, no single test, including motor or somatosensory evoked potentials, could consistently differentiate responders from non-responders, though some trends were noted. For example, responders were more likely to have an intact soleus H reflex and a normal fibular compound muscle action potential, suggesting that peripheral nerve and reflex arc integrity may play a role. Conclusions. Transcutaneous spinal cord stimulation can enable meaningful voluntary motor activity in some individuals with motor complete SCI. However, response is variable, and we currently lack reliable biomarkers to predict who will benefit, highlighting a key area for future research. Finally, in a reminder of the importance of rigorous testing, a randomized controlled trial in the Archives of Physical Medicine and Rehabilitation delivered a negative result for a different neuromodulation technique. The study. This Phase 2 trial investigated whether adding translingual neurostimulation, or TLNS, to a 14-week physical therapy program improved gait and balance in people with multiple sclerosis, compared to PT with a sham device. Results. The primary outcomes were the dynamic gait index and fast walking speed. The study found no significant difference between the group receiving active TLNS and the group receiving sham stimulation on these or any other secondary gait and balance outcomes. It is important to note that both groups improved significantly from baseline, reinforcing the known benefits of physical therapy for this population. The group receiving active stimulation did report greater improvements in cognitive fatigue and mental health quality of life, but this did not extend to the primary physical endpoints. Conclusions. This well-conducted trial demonstrates that, at the dosage provided, adding translingual neurostimulation to physical therapy did not confer any additional benefit for gait and balance in people with MS beyond that achieved with PT alone. Our final segment is a perspective piece from the American Journal of Physical Medicine and Rehabilitation that issues a call to action for the specialty's future. The authors argue that as cellular and gene therapies move from clinical trials to approved treatments, physiatrists are uniquely positioned to take a leading role. Many of these novel therapies for neurological and musculoskeletal disorders use functional outcomes as their primary endpoints. The article posits that PM&R physicians, in collaboration with specialties like neurology and hematology, should be driving the clinical translation and implementation of these regenerative treatments. This is a timely opportunity for our specialty to influence the development of what could be transformative therapies. If you only have time for one paper this week, make it the study on hip fracture rehabilitation by Huang and colleagues in clinical rehabilitation. The finding that over half of older adults receive no rehabilitation after a hip fracture, and that this is associated with a 17% increase in 3-year mortality, is a powerful and actionable piece of evidence. It's a stark reminder of the life-or-death importance of advocating for comprehensive, integrated post-acute care. Here are the key takeaways from this week in physical medicine and rehabilitation. First, for older adults post-hip fracture, a lack of rehabilitation is common and associated with higher 3-year mortality. We must advocate for integrated inpatient to outpatient rehabilitation pathways with an adequate dose of at least 4 sessions. Second, in post-stroke rehab, robot-assisted gait training is not universally superior to conventional therapy. The choice of device matters significantly, with some showing benefit and others potential harm, underscoring the need for tailored device selection based on patient characteristics. Third, transcutaneous spinal cord stimulation shows promise for restoring some voluntary movement in motor complete SCI, but about half of patients may not respond. We currently lack reliable biomarkers to predict who will benefit. Fourth, a structured, nationwide post-acute care program for stroke, like the one in Taiwan, can lead to substantial functional gains, fewer readmissions, and significant cost savings compared to traditional care. And finally, be critical of new technologies. A randomized controlled trial showed that adding translingual neurostimulation to physical therapy did not improve gait or balance in patients with MS, even though PT itself was clearly beneficial. That's your roundup for this week in physical medicine and rehabilitation. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.